Thank you, Dr. Burston. That was a wonderful introduction to our day, and really, I'd say, a perfect overview and outline of what we want to get into in more detail today in our discussions of the key issues and questions. So thank you all for being here. Before I begin, can we just have another round of applause for Dr. Burston? And can I also invite our reaction panel to come up to the stage? So thanks everyone for being here. We're really pleased to have such a great attendance here at the forum today. My name is Keavney Klein, and I serve as Senior Counsel for Policy Issues on our Government Relations team at Kaiser Permanente. As part of my role, I have the privilege of working across our organization and externally on a variety of policy issues, national and state, including I have the privilege of working on our telehealth issues, which I have very much enjoyed. I've been working on telehealth and related issues, as well as provider network related issues for about 5 years at Kaiser Permanente, and I have to say I'm pretty lucky to be in that space. I get to see a lot of the cool innovations that we are doing as an organization across the program, including obviously the technology itself, but also how we're implementing it day to day, as well as in pilot stages as we're testing and proving new innovations and new applications. So we titled this forum, Leveraging Telehealth to Expand Access to High Quality Care, with an emphasis on the quality. Just as not all in-person care is equal, not all telehealth is equal. At Kaiser Permanente, we work to ensure that members and patients receive the right care at the right time, at the right setting, to meet their clinical needs and their care preferences. And sometimes that setting is their home or their workplace via a telehealth modality, because it is with their own doctor, oftentimes, who has their medical record available in front of them and has a history with that patient, it's more convenient for the patient and timely and often more timely care. That patient can then get back to their day and their responsibilities after having their clinical issue taken care of. And that, in Kaiser Permanente, to Dr. Burston's point and to Murray's point earlier, it's woven together with the rest of their care. That integration is part of how we deliver telehealth. So that encounter is treated like any other, where the physician's notes are made in the patient's medical record after the video visit or phone visit. Prescriptions are sent to the pharmacy, lab and imaging orders are entered, and as needed, follow-up or specialist care appointments are made. At the same time, it's very possible that a telehealth encounter is not what's needed. So as part of our clinical and operational workflows, we ensure that patients can get the next available in-clinic appointment with their doctor or their other provider, another member of the care team, as that's appropriate. So we believe that within our integrated delivery system, this works very well, and we'll hear more about how that works when Dr. Trong speaks later. And we know that our members and our patients want access to care through these modalities. And so, as a member of our government relations team, I spend a lot of time developing our talking points and advocacy points around how we expand telehealth. And we have, a number of barriers that we're working on addressing. To Dr. Burston's, major points, reimbursement is a key barrier to the general expansion of telehealth. As we are, and the primary barrier, as I think Dr. Miller will get into, is in Medicare. And we have a situation where only a very, very small minority of patients across the country, Medicare beneficiaries, can get access to telehealth. So in the Medicare Advantage space, we spend a lot of time advocating around the value for the Medicare beneficiaries. We do see our Medicare-aged members and our Medicare eligibles wanting to access care via telehealth, and so we spend a great deal of time thinking about how can we really demonstrate the value for Medicare members in the Medicare Advantage space. We've had more than one meeting with Dr. Miller and staff during his time at MedPAC. We also have expressed support for legislation that's moving through Congress now that is intended to alleviate some of the challenges around Medicare Advantage coverage that would allow for Medicare Advantage plans to include telehealth as part of their basic Parts A and B bid. But Medicare is not the only area where we advocate. We certainly are attuned to what is happening at the state level, and we do see more and more expansion and opportunities for plans, health plans, to cover and pay for telehealth. So the doors are being opened, but again, we do have these reimbursement barriers and other key issues that we need to address in order to tip the scale for where plans and where employers will want more and more telehealth and want to be able to access. I think the idea that when there's a critical mass of patients demanding access, just like we do in the banking context, in every other context, in transportation, we will see greater investment there. So the other areas where we are participating in some of policy discussions are at the state level around licensure, and so we're supporting the interstate compact legislation from the Federation of State Medical Boards. That is an area where we're pushing our state regulators and legislators to act. We're also working with the state of California on their effort to extend e-consults, where the provider-to-provider engagement is allowed and more open for specialists to be able to engage with primary care providers, potentially in more vulnerable areas of the state. And so while we, as a Kaiser Permanente, do a fair amount of e-consults internally already, we are working with the state to help them educate DHCS and others, Department of Healthcare Services, so that can be extended to others. So with that as an introduction, I'd like to introduce our panel, who will grace us with a few minutes of introduction, and then we'll be able to get into questions. So first we have Donna Kinzer, who is the Executive Director of the Maryland Health Services Cost Review Commission, where she has led her staff and the field through transitioning Maryland hospitals to global budgets. They adapt Maryland's quality improvement programs to the new model, develop new payment policies, analyze potential avoidable utilization for hospitals, and implement broad stakeholder input approaches. Next, we have Brian Marcotte, who is the President and CEO of the National Business Group on Health, the nation's only nonprofit organization devoted exclusively to representing large employers' perspectives on national health policy issues and helping companies optimize business performance through health improvement and healthcare management. Next is Dr. Mark Miller. He is the recently appointed Vice President of Healthcare at the Laura and John Arnold Foundation. Prior to joining the foundation, Mark served for 15 years as the Executive Director of MedPAC, the Medicare Payment Advisory Commission, which, as we know, is the independent congressional agency established to advise Congress on issues affecting the Medicare program. Mark also previously served as Assistant Director of the Health and Human Resources at the Congressional Budget Office and as Deputy Director of Health Plans at CMS. And finally, Dr. Sandra Wilkness, who is the Program Director for the NGA Center for Best Practices Health Division, focusing on issues related to behavioral health and social determinants of health and the innovative integration of these into the health system transformation efforts. She leads NGA's technical assistance work with states to advance programs for high-need, high-cost populations. So I'd like to welcome our panel.